My name is Dr. Aaron. I am Bob Aaron. I'm a GI attending in Tulsa, Oklahoma. I've been with ACLI for the last few years. I was actually elected as a resident representative to the board when I was a fellow. So I kind of got to jump in to the deep end very quickly. And part of that has been being a part of the solid program and these discussions and learning exercises. So it's been really great. Today, we're going to have a pretty fun discussion. We got a couple cases for the difficult patient. So we'll kind of go through a couple different cases, a couple different scenarios that medical students might run into, and actually physicians run into also, and how we might tackle them. You'll get a couple different points of views. We have some great guests here to help with us. Dr. Kurilla, she's an associate professor for internal medicine at the Department of Primary Care in Kansas City University, the College of Osteopathic Medicine over there in Kansas City. And then we have Dr. Lightfoot, Judith Lightfoot. She's the chair of the Department of Medicine. She's also the chief of infectious disease and associate professor of medicine at Rowan Virtua School of Osteopathic Medicine. And then we have Dr. Layer, who is also a frequent attendee of these meetings. We all are, I guess, at this point. He's an internist for the internal medicine, ambulatory, and inpatient rehab. So I appreciate everyone being here. Hi, and I appreciate everyone else being here. And we'll make this kind of a fun discussion. We'll kind of see if we can't go different ways on these topics and pick them apart and kind of maybe shed a little different insight on some of these. For all the students out there, if you're listening and you have any questions or anything pops up, feel free to say something. This can be pretty open. I think discussions like this work better as a conversation than as a lecture, because I think you get to touch on more nuance. And, this is the kind of time where you can ask questions that maybe you wouldn't want to ask someone else on rounds, because, this is the whole point of this is to ask questions and get comfortable with what to do in these weird situations. So all that being said, I'll go ahead and kind of go to the next slide, the first slide, and we'll kind of talk about our first case. All right. So these are all real cases. A lot of these are submitted by the students and by other people who have actually been in these situations. So if they seem awkward to hear, they're more awkward to live through. All right. So our first case, we have a 63-year-old male with a medical history of hypertension who was brought to the emergency department by EMS. He was found down in a confused state and then also seen wandering around a gas station. He has a history of long-term incarceration for second-degree murder. During the pre-rounds one day, me, the medical student, was palpating his abdomen when he grabbed my arm and asked, "What race are you?" He opened up how he did not trust anyone in the hospital because they were all white. He told me, "That's why I killed that white bitch. She deserved it. They all deserve it. I would do it again. And when those white bitch doctors come in, I just want to punch them." So that's pretty aggressive and can be pretty triggering. Has anyone been in a situation like this? Dr. Layer, have you seen situations like this? Dr. Lightfoot?
Yes. I've encountered patients that are resistant being seen by a certain either gender or ethnicity. Mm-hmm. And my opinion, sometimes it's involved me, sometimes it involves a member of the team. And most of all those scenarios, I kind of navigate two things. The patient's request, but also the colleague's comfort level. And because I don't want somebody else on my team to be made feel uncomfortable. And usually how I've navigated it is try to find a way to, both people don't want to be in that situation, whether it's appropriate or not. And so try to make the patient comfortable, but also not make the colleague feel, I guess, worse off, by having them be exposed to somebody who's maybe saying something inappropriate or not appropriate.
Yeah, I agree. It's very tough to have to be professional and mediate and figure out how everyone's going to react to that sort of situation. Dr.
Yes.
Lightfoot, how would you handle a situation like this?
So I've been in that situation several times. One in my fellowship with my residents and students at the bedside, and was doing infectious disease consult. And initially, the consult went well. And then when the attending came in the room, a lot of expletives were said about my race and who I was. And it was very different from when I was just there maybe an hour ago with the students and the resident. And my attending felt very uncomfortable and told the patient, "We're here to help you, but I won't let you speak to her that way." And I said, he said, "We will do the consult, call the primary team." And I said, "Just a second, he needs help." And not that I condone what he said either. And I think sometimes you're going to be in these situations, but I figured that I thought he was septic and maybe that had an altered change of mental status. At the same time, I realized that some of his behavior ran very deep. It was the beginning of the year, like July, when the fellows are new, the residents are new, students are new. So it was late, around 7 or 8 o'clock. And when the attending decided that we will call the primary team and tell them we're not going to do the consult, all of a sudden they called code blue, probably when we got 10 minutes down the hall. And it was room 454, bed B. At that time, I was probably the most senior house staff in the hospital at 8 o'clock at night. And the resident, who's now a nephrology attending, and the other one resident is now a pulmonologist, looked at me as what to do because it was their first night in their roles. So I had to put everything, every negative thing he could say about me, and realize that I was there to take care of patients. And I had to be professional and do what I needed to do to get him to the ICU, intubate him, mainline him, and float a temporary pacemaker all in one evening in the ICU to do what I had to do. Well, the next day, 2 days later, I chose not to go in the room in the ICU. I didn't want to upset him or deal with his derogatory comments when he was extubated. My attending went in and told him that your behavior is unacceptable, but we will take care of you. Dr. Lightfoot's not coming in the room. But I later went back after rounds so that he could see that I had a hand in trying to take care of him and saving his life. And that I would do that for any patient, even though for a moment he didn't want to give me a chance to take care of him. But I did what was appropriate, as I would always do. So I think when I had to remember back, in students or attendings, when you're facing a situation, you have to remember why it was your calling to medicine. People's personal feelings, their past experiences, and what they've gone through could not totally take over the moment on what needed to be done. He was there for care, and I was there to render care. And although I felt I didn't like what he had to say, but just think if I didn't help him. That's not why I became a physician. I wanted to help all people. And I hope, and I don't know, but maybe, I don't know, but maybe he had a moment or a thought later to give someone else a chance. And if he didn't, so be it later. It hurt for the moment, it did. But I've dealt with other things far worse. And that's why I had to remember from where I came from and my upbringing and where I'm from. But you're going to encounter that, and you're going to encounter things in which people are going to say things or they don't want to see you at all. or they're going to mistake you for the housekeeper, or they're going to mistake you for nothing wrong with nurses, but the nurse, and you can't be the doctor. You're going to get all kind of things like that because people's biases and their personal issues that they haven't dealt with, and they bring them no matter where they are. Hospital is just one place. So I still deal with that, and I've been practicing for 30 something years, 32 years. I don't let it get the best of me. I let it be a teachable moment and just try to show them my compassion and empathy that I have for the disease in which I'm trying to take care of. Because they didn't put me here. My father put me here, who I believe in. That's how I
That's a
dealt with
pretty
that.
amazing story. That's a fantastic story. I can't imagine how the other members of the team, from the residents to the students to even the attendings, can learn from something like that. Because it's you know, when actually called to action, when you're actually put there, how do you respond to that? And to respond so well and actually save this guy's life after all that, that's a pretty powerful statement about who you are and about who I think doctors are. And it's a great example for kind of all of us to learn from. That is pretty awesome.
I think we all would have done the same thing. I did look around to see who else was in the hospital. But at that time of night, the ID team was always known to round late. No one else. And it was the beginning of July, when it was like the first week. And I know the brand new house staff was everybody remembers when you're the brand new house staff and you're looking for someone, would you just stay while I do this? And I couldn't leave them. So, anyway. So I think all of us would have done, you just have to ignore some things and do your job and do what you're taught to do, and why we were driven to do medicine and chosen. It's a privilege to practice. I'm not saying be abused, but remember, I'm there for a higher reason, I believe, than man himself.
Well, and that kind of leads us into maybe the next case. You kind of touched on something about maybe his mental state. So I'd like to maybe move on to this next case. So
could I make a comment though?
100%, absolutely.
Okay. And Dr. Lightfoot, I can't possibly, I mean, that's a tough act to follow. That was a powerful story, and I agree. And I think that the barometer that we need to keep, the compass has to be the patient. And that's why we are there. And it's tough to put those feelings aside, but you do what needs to be done. But one of the things that I was concerned about, especially considering that I might be the white bitch attending coming in, which is another matter entirely, and I put my feelings aside for that, and it's been called before, but the concern about the actual safety of perhaps a medical student alone in the room with that kind of an individual who has committed murder. So I think that, I think we still need to do that balancing act of trying to take very good care of the patient. And like Dr. Layer said as well, don't put yourself in harm's way, either emotionally, mentally, spiritually, or physically. But I could see where it might be a consideration to say, either a pair of you go in to pre-round on this individual, or maybe nobody pre-rounds on this guy, just for safety's sake and for their emotional stability, and especially the newer they are. I mean, there are times you don't want to protect them, you want to discuss it, but again, the safety issue. So that's really what I wanted to add on.
There have been times too, we've called, in that situation, if attending couldn't calm the situation down, like Dr. Lair said, we've had to call security to the bedside to explain to the patient that that kind of language or that kind of behavior will not be tolerated, so that the medical personnel could do what they needed to do to help them. And even as a chair of a department, I've had to utilize security to keep my staff safe.
Sure.
Yeah, advice for medical students. Yeah, advice for medical students. If you're ever in a situation, feel free to ask nursing to always partner with you when you're examining these
Absolutely.
patients, and always leave doors open.
Yes.
Patients always act a different way when, they could have an audience. And then 100%, don't discount your personal thoughts or however you feel a situation is going. Listen to yourself. If it's uncomfortable, then just move on, let the team know. Nothing is so important to put yourself in an uncomfortable position. You never know who's in a room. You got patients, you got family members,
And make
and
sure
sometimes
you're
it
the
can
one
be
closest to the
intimidating.
door.
Yeah, always 100%.
Yeah.
Yeah. Patient U door is a good
Yeah.
safety idea. And as a little, maybe a bonus point, if you're the medical student, you hear that, not only are you telling your team, tell the nursing staff too. They'll
Yes.
like you for it. Because when you're the physician, you're also responsible for the safety of the team. That
Mhm.
includes the nursing staff and the RT and even the house cleaners. So make sure everyone's aware of this.
Mhm.
Good case. A lot to learn from that case. A lot to learn. We could probably dissect that for a whole hour. Next case. So we have a 49-year-old female with medical history of bipolar, PTSD, and borderline personality disorder. She was brought to the ED by EMS for manic symptoms. Among the questions she asked me over the course of the week were, I noticed you're not wearing a ring. Are you married? You look tired. Were you up late sleeping with someone? Your perfume smells very nice. I'm sure you're wearing it to impress someone special. One of the most unusual questions she had about my personal life came about when she was describing her son to me. At one point, she ended up saying, he's a beautiful boy. He's also a virgin. He prefers olive-skinned women like yourself. Would you be interested in taking my boy's virginity? That's a heck of a patient right there. Dr. Kurilla, how would you go about dealing with a patient that has some psychiatric issues, but is also
Yes.
crossing a very bold line?
Well, I thought it was interesting that there was a sort of a sequence of advancing depth to the invasive questions. And, I could see myself initially just kind of laughing it off as far as like, are you married? No, yes, whatever, And, but then about the sleeping, in that second question, I think I wouldn't, I could find myself not even believing that it was asked. And so you have to be careful, because if you laugh inappropriately, and particularly if the individual has mental and emotional issues, or maybe medication imbalance for whatever they're on, they can take that a number of different ways. So you have to be careful with that. And I think at that point, you might just say, yes, I'm tired. Thank you for your concern, and leave it at that. I could also see the patient then countering, well, what were you doing? And being more persistent. And I think there's a point where you draw the line. You just set the boundary. And, that is not your concern. I'm here as a care provider. You're the patient. We're going to get you feeling better. That's not issues. Those aren't issues that we need to talk about. And as far as the whole taking the boy's virginity, I mean, that would have floored me. That got me. And I could see myself, and this is one of those that leads into the next case even. No, ma'am, I would not, is probably what I would say, to curtail it and make it final. But it won't end there. She's going to keep on with inappropriate questions, because she needs some help here. These are not things that most people would ask. But again, I think reinforcing the roles and reinforcing the boundaries. But I also wanted to share a flip on this that I found rather sad, because I had an attending who was probably in her 40s. And this is when I was a resident, and the patient was 90 plus, little sweet, sweet, sweet lady. Nothing malicious in any bones that she ever had left, right? And as the attending was listening to her lungs and, checking her over and visiting with her, she said, when she first introduced herself, I guess, she said, oh, is that your maiden name or your married name? And this woman took extreme exception to it and said in a very stern tone, "That's my only name." And the poor lady just kind of shrunk into her seat. I mean, it's like she meant nothing by it. So again, kind of looking at the context and looking at, like, this patient had a lot of serious mental issues and came in for manic, mania. So there's a lot of other confounding things. So even an age difference can make a difference. Gender differences can certainly make a difference as well. When she started talking about, he's a beautiful boy, I thought we were going to go down a different road. And the other challenge that I have, again, bridging the future cases, is I was raised pretty traditionally, and yes, ma'am, no, sir, that sort of thing. And that's a reflex of mine that I have to be careful with nowadays, because some people take exception to being addressed as that. And I know we'll talk more about that with the other cases, but that's pretty much my take on it.
Dr. Lightfoot, have you been put in situations like this?
I think she hit a lot of the points where you just have to keep redirecting the patient back to bring them back to center as to why you're there. And they want to tend to get off topic. Yes, it's always with an attending. We thought she was joking. Happened to be the late, great Dr. Patone, nephrologist. And she was 86. She was very cute. But she inquired so much about his personal life and about his wife.
Ooh.
And then she said, I'm so embarrassed to say this. She said, "But wouldn't you like to go to bed with me?"
Whoa.
And he said, "Excuse me?" I mean, he turned so red. He couldn't believe what she said. And he had a way of having a conversation with the patient. I don't think we set up bedsides anymore. We don't. On a part of the patient's bed. But that was the way you talked. And when I trained to get your points across, you spent a lot of time talking to them, trying to convince them. He was trying to convince her for the need for dialysis. I guess one could make the argument that maybe she was a little uremic, maybe needing that dialysis a little sooner, but that wasn't it. She was sincere, and she was talking about her dreams. But he caught on. He says, "Your line of questioning is inappropriate," he told her. He says, "You have to stop this. Otherwise, I can't take care of you anymore. I have to turn you over to my partner. And every time I come in, you go right back to this. And I can't have that. My wife is none of your concern. My family is none of your concern. You're my patient." He said it right there. And
Definitely important to make a line like that.
and it was a teaching point for us.
Yes.
If you don't get ahead of it, she could have said anything. And by the way, and this is when there was a time when we did not allow male students or male physicians to go in, and we still don't, but I'm dating myself now, but to go in a room by themselves. They had to have witness to their conversations. And now we even encourage female students, to have a witness to your conversation as to what was said and how it was said. Is so important. But you want someone else to be there as a part of the witness to the conversation, that he was not flirting with this 86-year-old grandmother or great-grandmother to some, that he didn't make any accusations about wanting to sleep with her. But she was very much making all the other accusations. So you have to redirect the conversation. So I agree with what you said and getting them back. But sometimes some can, if they're bipolar or if they have histrionic, sometimes when you turn them down or say no, or I can't be a part, then they'll get histrionic and accuse you or make other accusations.
Yeah.
That's where your witness comes into play. So it's a lot of ways to address this, but when you're uncomfortable, or never be alone, take another student with you or have an attending there as you ask your questions. But you're going to encounter this. You're going to encounter this at every stage of your career. And where some things are misinterpreted. Now we type when we're in room, something we never did before. We may have jotted a few things down, but in order to keep the pace, we type as we go or pluck as we go. I do more plucking. Or I say, just a second, let me dictate this. I want to make sure I get it right, just the way you said it. People think about what they say and how they say it when I say that, which helps me. But anyway, but yes.
Dr. Lair, have you seen things like this in your practice?
Yeah, I mean, people will say various things on appearance, but if it crosses that line of being uncomfortable, or you definitely got to set boundaries. I had one attending, the minute they would bring up, and it was kind of more to get to know the person, but if they started asking him about his family or, things like that, he would immediately put that firm boundary down. And, it actually sometimes felt a little too aggressive. But it definitely curbed the conversation quickly, because at the end of the day, the redirection he would always say is, none of that's relevant for me to take care of you. And I want to address all of your concerns, your questions, and I want to dedicate all my time to you. And that would soften it a little bit. But that's really just the most important thing. And I would personally just say, from a separate friend, he's an ophthalmologist. He used to be more sharing of his personal life, because people would ask, and he would even share some of his stuff with his staff. But then he actually had a patient's mother died, and then, or I'm sorry, the patient died, and their son then started stalking him and actually was threatening him, and was, because they knew enough personal information, actually stalked his daughter from high school down to where she was participating in after school activities. And he went as far as within a week, he moved out of his house, moved his whole family, even changed practice locations. I mean, because it was building. And from that, his advice to me going forward was ultimately maybe you don't even share, with your staff when you have an office, don't ever do anything at your own house. Maybe always do it at a restaurant. Keep those boundaries kind of even for everyone, just because you never know where that information is going to be taken. So.
Good point.
It gets real.
Yeah.
We got a third case. This is a 39-year-old non-binary individual presents to the ED for acute onset palpitation in the setting of cocaine intoxication. I assumed the patient used they, them pronouns. During my history collection, the patient corrected me and said that it was a she day. This went over my head, and when I was performing the physical exam, I referred to the patient as they, and the patient once again said, I told you it's a she day. The patient used a pronoun schedule that assigned preferred pronouns depending on the day of the week. Since it was a Tuesday, the patient was using she, her, hers pronouns. This is also the case for Thursdays and Saturdays. On Mondays, Wednesdays, and Fridays, the preferred pronouns were he, him, his. And on Sunday, this was a wild card day, but she told me that she usually was they, them, theirs. Dr. Lair, I'll stay with you for a second. How do you navigate figuring out the appropriate pronouns to use with patients?
From my experience, I work at a place that has Epic, and one of the things they did maybe about 2 years ago is the front desk or in intake, they ask every patient what they would like to be called, and it actually highlights it up with their name. And me personally, with this patient, just so I wouldn't step in hot water, I would make them feel uncomfortable, I'd probably just refer to their name and just call them by their name, probably by their first name the whole time. So then and I'd make a note of that and keep it. That's how I would probably approach it. But from my experience, most of the time, the patient that prefers specific pronouns will tell me ahead of time, and then I just honor that request. I haven't made anybody upset. I don't make it a habit to ask, because from my experience, I've actually had more patients get upset. So I kind of take the lead from the front desk, and if they let it known, and then I let the patient tell me what they prefer.
Yeah. Dr. Kurilla?
I kind of take the same approach that Dr. Lair has described. I'm not one to put it on my name tag or present it. And when I introduce myself, I find that very awkward, and it almost makes it standoffish if I say, and my preferred pronouns are she, her. So I don't do that, and I don't specifically ask. And currently, I mean, I think the climate is such that most of the EMRs have those methods so that you can establish the gender identity. And it's a wonderful luxury, really, to have that available, because otherwise, think of the sticky times when you had to navigate the waters and ask the patient the question, and nobody was informed enough to ask anything intelligently, even maybe perhaps. Again, that brings up the sir or ma'am challenge, that I know I would fall into that trap, and then I'd be apologizing, because those old habits die hard, and you'd have to, just hopefully the patient is gracious enough to be forgiving. But I think this particular challenge is not consistent. And I don't know how common that is. And it would be a challenge for the EMR, even if it was. And when I first read it, and I read it was she day, I thought she day was the phrase that meant something different that I hadn't heard of, until I read further and discovered it was the day it was a she. So very awkward. And I try to be as sensitive as I possibly can, and as apologetic as I possibly can. But that is a challenge.
That's it is difficult. Dr. Lightfoot, infectious disease. I'm sure you have taken care of several patients with HIV/AIDS. I was in the HIV/AIDS clinic. A big part of that population is gender fluid, or not necessarily binary. How do you navigate this in your practice?
It's still a challenge because Epic doesn't get it right, because we found out legally that unless they have it legally changed on their driver's license, you have to call them the name that is on their driver's license. However, we just wrote a proposal to change it, to put something in parentheses, because my patients will correct you, and it will be a TIF if you do not call them by their correct name. I deal with transgender, transsexuals, other. And I get the patients who said, today I'm not this or that, because I deal with a lot of psychiatric patients. And it depends on what mood they're in and what day of the week. That's a real scenario. And the hospitals where I am in, they put it actually on top of the board, how they want to be addressed. And if the nursing staff or the aide doesn't put it over the board, they'll put it on the board themselves, because they get tired of, as the patients tell me, I want to be addressed as, this is how I want to be addressed. They find it very offensive, and it really shuts them down, or they're not addressed the way that they want to be addressed. It'll cause them to leave a visit. I'm just trying to deliver care.
Right.
So if my front desk doesn't get it right, Epic doesn't get it right, because they tell me I cannot call them, but I call them what they tell me to call them, but in the system. Because haven't we been smart enough to fix it in the system? But if the documentation does not support Ebony, because her name is Ebony, even though Michael is her name, she hasn't legally changed it, we address her as Ebony because we know her. But if she were to come to Dr. Lair's facility, he will call her Michael. Ebony doesn't exist because it's not on her driver's license. And Ebony will correct Dr. Lair and everyone in Dr. Lair's office. And it will be something. I mean, it got to the point where even for surgery, same-day surgery, even for colonoscopy and anoscopies for this particular patient. So it's too much. I mean, the bathrooms have all been changed. Everything that you can think of at, Rowan Virtua has been changed. We thought we covered everything, and we still don't have it 100% right yet. So I think by what year am I retiring? Let me see, wait a minute, we're in 24. By 2025 or 26, hopefully we'll have everything fixed. I'm hoping. I'm hoping because there are more in my population. You look, you think it's this, but it is not. So who said just tell me, how would you like to be addressed?
Right.
Or what's your name? Or give me your name again, please. I just don't have something. My swipe on my computer is not acting right, and they'll tell you their name, and then I got it right. That's how I deal with it. Especially if it's a new patient. A new patient will walk out.
Yeah.
We've had that to happen. Or they'll tell you about your staff, and that's 5 minutes of the visit when I could have been getting information. But it's very sensitive to them because, and I get it. I get it.
Yeah.
I get it. For the students who have had to code them, or the residents who've been in a code. And I remember this is St. Agnes, good old Catholic hospital in Philadelphia, when I was an intern, and I'm coding, and then they said the patient needs a line, and I'm putting in a line, but the top looks like female, the bottom is definitely male. And I'm like, but, they're like, keep going, Lightfoot. And I'm like, but it was a shock to me at the same time. So what do? We just put the line in.
Keep going.
We do. So it's an eye opener, but we deal with it. And but it does make them, because all their lives they've been challenged, and to come to the doctor's office or where they get their care, it's to have a challenge there because they're coming to us for understanding. And I always tell my front desk, you're the first person they see. They come to us for help when we don't get it right. And I'm not blaming them, but we got to get it right from the door. Just stick something up, text me, or say so-and-so is coming back. I'll take it from there. Makes a difference. But you're going to face this. All of you are going to face this.
Yep.
Oh, yeah.
And I don't think we can warn you of every variation there's going to be, because it is so fluid. And even within different portions of the population and communities, the terms that they use for themselves have changed. So I think the bottom line still goes back to Dr. Lightfoot and everybody's approach, that it is all about the patient. And as long as we try to maintain that care and convey that care without stepping too much on our words.
There's a major lawsuit going on right now in one of our medical hospital systems in our area. I can't believe, I don't want to believe that this actually happened to one of my patients, but without saying too much about the case, they misunderstood who she was. And what happened was a complication from a bariatric surgery. But when she came back in through the emergency room, apparently they examined her in the hall. And I know we don't train medical students to do this. The story sounds a little bit out there for me to believe. But if what did happen and is under investigation right now, that they actually took their phones out and videotaped this, then every one of those students should be expelled. Yep. If that was put up. But I cannot believe that this is happening, that this really happened. And it was because she's different. And she's in a psych hospital right now because this was so traumatic for her. But I cannot believe that this really happened. I refuse to believe it. It's an investigation. I'll find out more. But what we do, everything is on us as students, as health professionals, all the time. But I cannot believe, and I really hope that this is not what they're saying that's circulated on the media. And it got out. But a couple people are telling me, yes, it did happen, Dr. Lightfoot. I said, no, it can't. I'll wait for the investigation to come out. But it changed her. It really did. I mean, she won't come out. The doctors are keeping her. It's a breakdown. It's a breakdown for her and who she is, because no one has ever understood her in her mind. But anyway, that's deeper than what we're talking about right here. But those pronouns matter, and who they are and how they want to be addressed does matter.
I have a question for the other attendings. When it comes to documenting it in the note, how are you documenting? Because there's one way to, definitely say it and address the person when you're talking to them. Do you maintain that same method when you start writing your note?
It's my first sentence.
Mm-hmm.
This is Todd, male to female transition, goes by he, and I just try to keep he the rest of the time. And I feel like that helps. And I'm pretty blunt about it when I ask. Because if I don't know, I've learned that if I'm just, hey, do you take blood pressure medicine? Do you go by he? You know, when was the last time you had your colonoscopy? I try to keep it as routine as possible if I don't know. I've also learned for the medical students, there's a yellow sticky note and a blue sticky note on Epic. If you ever work with Epic, do not mess this up, but yellow sticky note is for you and blue sticky note is for everyone. And if there's ever I write my own little notes on yellow. This patient gave me cookies one time. This patient's, you know, daughter went to college. This patient was really mean to me last time. On the blue sticky note, you can write things. That's a great place to write. So everyone who opens the chart would see, goes by he, him, has a day where they go by she, whatever it is. So, but it is tough. And I'm sure it's different. Every place you go in the country will be a little different, and there's no way to get on top of it. So just learn to roll with the punches. And speaking of rolling on, this is a fourth case, difficult one. Case 4, the patient's a 54-year-old male with metastatic renal cell carcinoma who was admitted for pain control. He had failed maximum chemotherapy and radiation therapy in control of his disease. Despite morphine infusion, he is having substantial pain in bones with severe headaches. During your evening rounds, he asked you assistance to stop the pain and suffering. As a medical student, if you come across a patient like this and you get into a heavy conversation, Dr. Kurilla, how would you advise these students to address this patient?
Well, I think that asking more questions, I mean, the title is I Want to Die, Help Me. And first of all, don't jump to that conclusion. It may be that the patient just needs, part of it may be that he needs someone to listen to him, as I guess yes, it is a male. But ask some questions and ask him to tell you more about, you know, how has it changed for you since you came in? But I think the very first step would be acknowledging that this is a very difficult process and things haven't worked out like he had hoped, and trying to acknowledge the suffering that's going on. And beyond that, I think just really listening to the patient, letting them talk, trying to encourage more. You have to be careful though, because it could be patronizing. And I think the patient may get very frustrated if maybe you're really trying to listen, but it doesn't seem like you're really hearing what he's saying. And so I think that, you know, I mean, hydromorphone is another option besides the morphine. So there is another option. Also, depending, and I know with the generalized bone pain, it's next to impossible to get ahead of it. And with the headaches, it's very difficult. So, you know, maybe talk with other colleagues and find out if there's other strategies that they may want to explore. You know, I mean, I can't help someone die actively by my principles and but that's not the issue. We're trying to take care of the patient. And one of the other things that occurred to me is to make sure, not necessarily in this conversation, but to make sure that the patient does have his wishes known in an advance directive and DNR if that's what he truly wants. So sometimes that gets, you know, it's a question that everybody's supposed to ask when the patient's admitted, but then they check a box and nobody follows up on it, whether or not they have an advance directive or whether or not they have it on their chart so you can use it. So that would be another thing to consider. I mean, this is a very, very difficult case because the pain can be just so all-encompassing. There's no escape.
Dr. Lair, how do you, what point in your training right? Because we're looking at this from a medical student standpoint. At what point in your training did you start feeling comfortable with talking about hospice conversations and end of life care, transitioning from aggressive care to a palliative care?
I'd probably say when I was an intern, because that's when it seemed to just be more effective. I mean, I was in medical school from 8 to 12, and I would say at that time, hospice and palliative care I felt was a smaller piece of medicine than it is now. It's much more common. It's kind of built in the ICU rounds and that kind of stuff, where it didn't really feel like that 10 years ago. So me personally, as an intern, as a medical student, I kind of just view it as an opportunity to be data gathering. You have the most time to listen, but the biggest thing to take away is, stress that you're going to convey that to the team, and you'll bring them all back, or we'll figure out a plan. And sometimes just that alone can help people feel heard and understood. And then when I bring up the DNRs and that kind of stuff with patients, I always tell them, as a medical, no matter where you are, we don't help people die, but we get out of the way of whatever may naturally happen. And so that's how I kind of phrase when we're talking about end of life care, of resuscitation and that kind of stuff. And that if you don't decline resuscitation, then we will always do our best efforts to save you, and that's our job. But with the post forms or the DNR type stuff, that's the patient's ability to express. And then I say, that we get out of the way of, whatever may naturally occur, and we honor that wish. And that's how I kind of phrase it, because I think only Oregon really supports, the opportunity for people to make their choice. But I think that's a year-long process.
Dr. Lightfoot, how would you coach medical students to address something like this if there's no attending around, and they may not actually know if this patient is a hospice candidate or not? Because I think going through training, one of the harder parts of talking about end of life care for me was, do I even know this is end of life care? Like, because you're not sure if someone's at the end of the road yet.
Yeah, and that's true. I think the listening piece is important, and asking the patient as you listen to them and try to quantify pain, and you may not know all the ways to measure their pain. If it's bone pain, it's pretty severe, but if they talk to all of their care team to see just where they are in their care. And that's one thing to ask them. And sometimes relieving pain for the moment is not the answer for tomorrow, but tomorrow is another day, and maybe sitting down with everyone that's involved to see, what are my options? Is it to continue what I'm doing? Or is it, what else do you have to offer, whether it's hospice, whether it's palliative care, but also explaining what that is. And maybe the medical student is not the one who's doing the explaining, but they're the observer of someone who is doing the explaining, where they're listening and they're learning, but they become a part of the team at that point. And then allowing the patient to make a decision. At that point. I mean, things have changed. I dealt a lot with this as a student, and as an intern, it was a lot different then, because we didn't have a lot to offer terminal AIDS patients. So we were making hospice plans and end-of-life plans for people in their 20s. It was a lot different in the 80s, 90s. With terminal AIDS patients, so it's all different now. But the situation came up today with one of our social workers. Her husband's only 47, just today, because he has end-stage lung disease. He's only 47. And he didn't want to go to hospice. To him was a dirty word. That was his description to me. And she had me get on the phone to try to explain, because that meant that he was giving up to his wife. And she wanted him to understand that she wanted to help him to relieve his pain and suffering. but he thought morphine meant a death sentence. These are his words. So people don't always understand
Mhm.
what we're saying, because morphine to him meant that you were going to put him to sleep, that was it. And so once we got a team out to actually explain, because she's a social worker, but she's his wife.
Sure.
And she wanted someone to explain to him that it's just to relieve his pain. She has no control when he's going to go, but it's okay to accept some relief of pain. So I think defining, as a medical student, listening, trying to coach the patient as to what do they understand and take that back to the team. Well, this is what Mr. Jones said to me today. And Mr. Jones is saying this. Mr. Jones is saying that. What about if we pull where does he stand? Because the medical student may not know everything about the case. But the medical student can be an integral part of bringing a whole team together to explain to Mr. Jones just where he is.
Mhm.
And
That's really good
therefore, and
advice.
be a part of the teachings of what is hospice, what is palliative care, whether he should continue this. And that student gets to learn and they'll develop their style. So that's what I would tell a medical student today, which is a lot different from what I would have a medical student's role back in the day would have been. I hope that's helpful.
I think that's excellent advice. We'll end on this last case, kind of circling back almost to kind of one of our first cases. The patient's a 62-year-old white male admitted with chest pain associated with ST segment depression and mild elevation of troponin. We are working the medicine hospital service and making your rounds. The patient was just seen by the cardiologist who wants to perform a cardiac catheterization. The patient is demanding a different heart doctor because he does not want a black physician. He uses a different term. It's Friday. The patient has unstable angina, and there's only one cardiologist available. Dr. Lightfoot, we had kind of talked about this a little bit. You had that amazing story. When you, that is a story when you are in charge. When you're a medical student and something like this happens to you and you feel like, you know, maybe you're not high on the totem pole yet, how do you go about navigating those waters for these people, these students that are going to come through rotations and see these patients, and they're going to get kicked out of rooms for this, that, or the other thing? How do you, what advice would you give to those patients or those students, excuse me?
Well, if the patient doesn't want to see the student, it's the patient's loss. I wouldn't take that as a negative as a student. I would just keep my head up high and go on to the next patient. It's their loss. It's the patient's loss. These things are reality. People have their biases, and racism just has not left this country yet. It has not. I see it in every form every day. So, although they may see my friend, but they won't see me. For a moment, you're thinking about it like, why am I not? What's wrong with me? There's nothing wrong with you. The patient in the room doesn't want to see you. There's nothing wrong with you. Just switch off the patient and go to the next, because I can't mandate that that patient see you. No one can. You just have to move on. I'm not saying it's acceptable, but there are a lot of patients in which that student can learn from. Now, it may turn up that that patient may have to see that student again on another service at another time. And they may be the same way, or they may soften. I don't know. I can't predict people's feelings. But I know one thing, that one patient is not going to stop that student from learning, and nor should that student allow that.
Dr.
So I
Creel, we have
say
a
to
couple.
the student, keep going.
Good advice. Dr. Creel, have you, how would you recommend the students navigate situations like this?
Well, I agree with Dr. Lightfoot, and I think it is definitely the patient's loss, but it's certainly not the student's role to tell them that. I think it's just, again, keep that head up high, know that you're a perfectly capable student. You have a lot to offer care to a lot of patients, and just bow out gracefully and don't take it personally. Don't let it get you in the gut because it hurts. I mean, there's, especially in different scenarios, you think you're on track and then maybe there's a turn of events or a turn of opinion, perhaps on the patient's part, particularly with those that we talked about with mental illness. And you can't predict that. You can't second guess it, but you can move on and just report to your attending what happened. And certainly then it can be readjusted as far as your assignments.
And let me back up for a minute. There's doubt, not just a black and a whitish, it could be the other way around.
Oh, yeah.
Mhm.
And it's
Gender.
usually an attending or another student trying to convince that patient that doctor's okay. He or she is going to take good care of you. What's wrong with you? Sometimes people, and my background is a mixture of Native American, African American, and other. But there's a communication with eyes, and you can tell when someone is uncomfortable. I can read faces very well. But I may circle back to that room. Do you realize you just turned down one of the best, such and such? And I go on with the patient. And what is your fear? I go right with the patient. What's the problem?
Mhm.
Because you're hurting yourself. So it goes. I don't want people to just think it happens the other way. It goes both ways. But I'm also there to say you're missing out on someone who can do great things for you, can help you. So, and it's just like, I don't speak Mandarin. One of my partners, Dr. Ho, I needed her for a case because the patient's family, they didn't know me, but they knew her, or they could see that she looked like them. And I think the trust would have been better built with her than me. The bottom line, the patient needed care.
Yeah.
So I just wanted to put that there too. It's not always a racism. It may be just, they're just not sure, they're uncomfortable, and they need some convincing. So, and the bottom line is the patient. I
Yeah,
hope that
patients
helps.
can request a different doctor. I mean, I've seen it for gender reasons, race reasons, training levels, perceived communication, like and sometimes you're maybe too blunt and direct with a patient compared to everybody else I've talked to. You know, I work outpatient and at a rehab hospital, and this patient had stage 4 really advanced cancer, and basically I don't know what stories they were being told by everybody else at the hospital, but when I told them, you know, what I saw written, and you know, people were communicating that prognosis was pretty poor, um, I was fired immediately because the family felt I was not on their same team. I wasn't as supportive, and most of that was just, I don't know what, maybe I was too direct, but nonetheless, we found him a new doctor and life kept rolling forward. And you don't get upset because at the end of the day, the heart of all these difficult decisions and cases is as long as the patient's always put first. And unfortunately, that means ourselves can be hurt sometimes. Just keep moving on. It's not a negative on you in any way. It's just the challenge of, unfortunately, we don't, when you're sick, it just puts you in a position where that person's always number one, and you know, sometimes as the physician you get put second or third. So
I think that's a very good way to kind of end this conversation. I think if everyone is trying to do best for the patient and try to continue to be professional in all senses of the word, but also make sure you have your own self-respect, because you've worked really hard to be where you're at. So you should be proud of who you are, and if you're doing the right thing for the patient, you're probably doing the right thing. We're at the end of our time today. If there's any questions, feel free to ask. But this is kind of heavy topic, and if anyone has any questions about what we talked about or wants help navigating, please ask. And I'm sure we're all available via email if you want something maybe a little more private.
I had one question. So you talked about how a lot of these cases can be really difficult and how they can kind of weigh on you. How do you navigate, I guess, like not taking it too personal or not taking it home with you, not letting it bother you? I mean, I've heard like brief discussions, but like are there anything specific that you do to kind of just let it roll off your back or not, carry it forward?
Excuse me.
I was told, and this isn't just for, I would take it as like negative experiences. So I think as a human being, we can take one negative, and I think the one study said you have to hear 7 to 8 positive things about yourself before you accept it. But it only takes one negative. And so I just try to stay focused on that. That if I am hurt by one of these decisions, keep the patient number one, and then keep in perspective of all the other positive experiences you have, because they always outnumber the bad, always outnumber. We don't always remember them. We don't always hold on to those. It's much easier to hold on to the negative if we want to. And so I just try to always remind myself of the positive experiences as a medical student, how your focused listening led to a good outcome, all those kind of things to kind of keep the energy up about it.
Dr. Lightfoot, how do you navigate that?
I think that's true. Sometimes you're not going to always get it right in your medical decision making. When you think back, you sit back and you reflect on cases, and everything is a teachable moment. Just remember that and learn from. If I'm just talking about in judgment, clinical judgments, and maybe that wasn't the best decision that you made for that patient, and you catch it, or maybe you go back and you read notes and somebody would have done something different, and you think later that maybe I should have thought about that in my differential and I didn't. Wow, did I hurt the patient? No, someone came behind me, or if the outcome wasn't what you expected. Um, think about it. Medicine's not exact science. We're trying to be, but take it as a learning. I mean, you want to learn, and it's not the term beat yourself up, just learn from it. There are always going to be cases that are going to stick with you, that you're going to learn from. And it's going to make you a better clinician, diagnostician than what you were yesterday. That's the beauty of medicine and growth of medicine. So look at it that way. And you'll remember for the next patient or everyone that comes before you that it doesn't happen, that kind of outcome won't come. But personal things like what people say, I agree. You got to let it roll. Don't let it get in your way. Just think of all the good things you tried to do today. And every day you try to bring your greatness every day, but someday sometimes it's not gonna be great all the time. But for that patient, you're trying to give them your best. That's all I can say. It's part of life. Look how you've made it through one of the biggest hurdles, and that's getting through school. Every exam wasn't an A exam. So think of it that way. But you got to the next one because you're still here.
That's right.
Would you like to add anything else, Dr. Kurilla, before we go?
I try to take it in stride, and I try to look at it from different angles if it's really sticking with me. Sometimes a walk in the park will help me, but it's just, life is too short to let these things pile up on you and get you down. So the other health habits that we talk about, try and maintain the sleep as best as anybody can in practice, and exercise and those things, which I'm not that good at. I'm still working. But the idea of those other basic approaches to good mental and physical health are helpful, and spirituality is important to me. And a friend of mine told me something that stuck with me too, that it was a very difficult day for him for many reasons. And then he looked at me and he said, but things like this, you have to, instead of ignoring, you have to till it into the soil as fertilizer for growth.
Nice.
And I thought that was really, really a good way to look, because it is all part of life. And embrace what you can and get the positive out of it.
All right, guys. Thank you all. Thank you for our guests and speaking and kind of helping us get through these patients. And it's good seeing everyone. And If you have anything else, please let me know, and we'll see you guys all in a month.